So it was this nurse, and she worked PD Psych, and they were doing I don't even know what like PD Psych nurses do. They were doing like a coloring therapy session or something with crayons or whatever. I don't like you do, because Psych is just so different from like every other anything. So she's doing this little therapy session or whatever where they're drawing pictures, and so backstory: this like little kid has like a mom and a baby, like a baby sister.
Oh, okay.
So it's this little girl, and she's drawing a picture, and it's a picture of this lady and a baby, and they're both like dead, and they're all like, there's blood all over and everything, right? And they're making like a gingerbread house or something.
Wait. So, this patient, is this something you saw?
No, I read about it.
Okay, you read about this, what, a teenage girl?
It was like a little girl.
Like a 5-year-old?
Sure, let's go there. Yeah.
Oh, so okay, it's like a 5 or 6-year-old is drawing a picture of her mom and baby sister,
right,
dead, covered in blood.
Yeah, but they don't. Okay, so so they don't know that yet. But it's just, so this nurse is looking at this picture, and it's this lady and a little baby, and a gingerbread house. Okay. And the lady and the baby are both dead, and there's blood all over in this picture.
Okay.
She like asked the little girl, like, who's making a gingerbread house? Or like, what is this of? And the girl said, basically, she said, like, both the mom and the baby are dead, and like I killed them. Then the nurse looks in the file, and the little girl has a mom and a baby sister.
Oh my.
Which is another reason I will never do psych. Because that would scare me. So like that would terrify me. I couldn't do that.
Oh my.
And it's like this little girl.
Ugh. Well, hello there.
We should just reflect on that for a second.
Oh, hi.
That's why they get paid so much, these psych nurses, because they have to deal with that.
I didn't know they get paid more.
Oh yeah, they get paid a lot.
Oh.
That seems to be the word, at least. I haven't like looked at a...
They failed to mention that in the brochure.
They mentioned it to us, but I was like...
They never show up to job fairs.
I was like...
They don't see the light.
You can pay me whatever you want. I'm probably still not going to do psych, because that's terrifying. They teach you self-defense in psych, because these patients will try and kill you. Anyway, hi.
Hello there.
I'm Matthew.
I'm David.
And this is the Handoff Report,
a podcast about the cool stuff nurses know and do, and why it matters.
So what are we talking about today?
I don't know. I'm kidding. I do know. We're gonna start with a scenario.
Oh, what about?
Walk with me on this journey. So, you're in the ER. You don't know how you got there, but you're there. Which is mostly how it is for me in the mornings.
It's tough.
Anyway, so an ambulance shows up and is wheeling in this patient on a stretcher. The patient's like 70-something. And you walk up and they are starting to tell you about the patient's symptoms. So that they say the patient fell down, the patient can't speak. You look at their face, the patient's face, and one side of the lip is drooping, kind of lowered down. And so you try to open their eyes, and one pupil, if you shine a light into one pupil, it will constrict. But if you shine a light into the other pupil, it won't constrict. It just stays fixed.
I feel like, who is it? The American Heart Association. They've done a pretty good job of like putting enough of these flyers up so that probably most of the people have like an idea of what you're talking about.
Exactly. This is a stroke patient. And in my ER, we get like 10 to 15 of these a day.
Ooh.
Yeah. So today we're going to talk about stroke, mainly the two kinds of stroke and how they present symptoms differently. So stroke is a big deal legally in the ER because there's all these goals. I used to work at Starbucks, and for 6 months I worked at a drive-through Starbucks.
Oh.
And so at the drive-through Starbucks, it's way more corporate-y and like bureaucratic and whatever the words are, because there's all these like time goals. Oh, let's make sure we're getting them from order to drink in 40 seconds. And it's like where everyone's just doing what they can to reach that goal. Stuff like that. No one's having fun. So so when it comes to stroke, the Joint Commission and the hospital administration, they have all these goals that nurses want to hit when it comes to stroke patients. And so usually one of those goals is how much time between what's called the last known well, meaning when were they last known to not have these stroke symptoms, the time between that and when they achieve certain milestones. And we're going to walk through that. But first, let's talk about the two kinds of stroke. There's ischemic stroke and hemorrhagic stroke.
Oh, yes.
So, and they both have some similar symptoms and different symptoms. So let's just explain ischemia. Ischemia is when there's some kind of occlusion in your bloodstream, and the phenomenon of ischemia is when you're depriving oxygen from what's downstream of the blood. So ischemia causes all like the classic acute illnesses. When you have a clot that is blocking oxygen from your heart, you have a heart attack. When you have a clot that's blocking oxygen and blood flow to your leg, that's called a deep vein thrombosis. Mm-hmm. If you have a clot that's blocking flow to your lungs, that's called a pulmonary embolism.
Right, and it doesn't have to be completely blocking.
It can be partially blocked.
It can be partially.
You're just depriving blood flow.
So it's not like necessarily, it's not getting any blood. It could just be not getting enough.
Yeah.
So it could be like a plaque buildup as well, causing
Plaque
an
buildup.
ischemic stroke.
Yeah. Plaque buildup. The key thing to remember is occlusion. So then, when it's in the brain, that's called a stroke. The brain has two halves, so when you deprive oxygen to a certain area in one half of the brain, it'll present symptoms to half of your body. So, unfortunately, sometimes there can be a stroke in the 2 or 3 places in your brain that's not split into halves. So I'm talking about your brain stem, or like the very center of your brain, what's that called? The bridge between them. What's that called? The corpus callosum.
Yeah, that one.
So there are areas in your brain where if the stroke happens there, then it's pretty much lethal, because the parts where your brain doesn't split into halves usually control automatic things like temperature and breathing.
That's like it'd have to be a pretty big clot, right? To clot there.
So let's see. In ischemic stroke, there's a clot that's traveled up to your brain and is now preventing blood flow to a certain part of your brain. It'll cause a headache, a really bad headache, and then you will get paralysis, meaning you can't move half of your body. But it will be to varying degrees. It's not like an on or off switch. How bad the stroke is depends on how bad your paralysis is.
How would you define bad?
So I think the best way for me to describe that would be to go through what's called the NIH stroke scale.
Ooh.
Yeah. So the NIH developed this standard way of measuring how bad a stroke is. And it takes a little practice, but once you get through it, you'll be able to do NIH stroke scales really quick.
Is NIH National Institute of Health? Mm-hmm. Just pull that one out of nowhere.
Bingo. So usually you start with by assessing their cognition.
Okay.
You ask, hey, what's your name? And
Abraham
where
Lincoln.
are you? Yeah. And so depending on how they respond, you give them a score of 1, 2, or 3. And when you're asking them their name and where they are or how they're doing, if the stroke is not that bad, then they might just slur their words a little bit, but know who they are and where they are.
Okay.
If the stroke is really bad, they can't talk. Like
So-
their ability to talk has been compromised.
So like, how would you if like let's run through. So I came in for a stroke, right?
Yeah.
So go through the scale with me.
Go through the scale with
Yeah.
you? Okay, so let's see. I have to remember each part of it. So I would walk up to Matthew and I would say, "Hi, sir. What's your name?"
My name is Barack Obama. What's my score for what's my score for cognition?
Well, now I don't want to get thrown in jail for hate crime. But
Okay, let's pick. My name is Jesus.
paged for a psych consult. No, so in a stroke, you wouldn't like say you're somebody else.
Would I just say I don't know who I am?
Yeah, let me demonstrate. When I've asked someone, "Hey, what's your name?" They'll usually, if the stroke was bad, they'll respond with, like that.
Okay.
So the stroke is so bad I can't even tell if they like answered correctly or not. So I would give them like a score of 0, or I'm sorry, no, the higher the score, the worse the stroke.
Oh,
So
okay,
they'd get a
okay.
score like a 2 or 3 or 4, whatever that is. So then I would ask, if they can talk, you can ask for them to repeat a common phrase back to you, and you're just hearing
Like for slurring?
yeah, you're listening
okay.
for slurring. The slurring will happen because half their mouth is paralyzed, right?
Right.
Half their lips, half their tongue is paralyzed. So usually I like to say, "Can you say God bless America?" Just because that's the only thing that can come to mind. I've heard other doctors use other phrases, but I heard one doctor say, "Can you say no ifs, ands, or buts?" And
And you say, "Oh, I don't want to be racist."
and the patient was like, "My name's not Alice."
4.
So yeah, I usually say, if I, "Hey, can you repeat after me? Can you please say God bless America?" And they'll usually just slur their words and say, "Bless America."
You voted for Trump, didn't you?
We're just slowly but surely careening into a dark political corner. Anyway, so you can also assess for their facial nerves by asking them to raise their eyebrows.
Oh,
You're looking
yeah,
for
yeah, yeah.
facial symmetry. If they have symmetry, they probably didn't have a stroke. They might have just low blood sugar or something like that. But if there's obvious facial asymmetry, then half their brain has a problem. So usually the questions you ask is for them to raise their eyebrows or smile.
Quick question. How would you differentiate between someone having a stroke and someone having, say, like hypoglycemia or like low blood sugar?
So the two present super, super similarly. They come in really weak, and they come in slurring their words, and they come in like not urinating, and they both might even have infections on top of it all. So in the ER, you have to do things like stroke scales, but also measure their blood sugar
There you go.
to see to kind of find out what the problem actually is. So measuring the blood sugar is one of the things you should do when
That's
you
kinda like
when you
your
have a
rule
stroke.
out.
Yeah, it's a rule out.
Okay.
Another thing you ask to find out the symptoms or how bad a stroke is to have them try to hold their limbs in the air, and you count to 5. So the next part of the stroke scale assessment is to raise their arm for them and then say, "Can you hold your arm up for me?" And then count to 5. On the good side, right, you'll see that they'll hold their arm up perfectly. On the bad side, it might drift down slowly or drop all the way. And so you would assign a different score based on that. You do the exact same thing for the legs, and then you also want to assess for sensation. So you touch their legs and you ask them if they felt it the same on both sides. Some people retain equal sensation. Some people even retain the same Some people can even hold both arms in the air, but their lip will droop, and that's still a stroke. It's just the symptoms didn't completely wreck half of the body.
Okay.
In a ischemic stroke, how would you treat that? Because we don't just want to leave a clot there in the brain. That'll only cause more and more and more damage as time goes on. So in the hospital, you have generally 1 hour to give a clot busting medication called Alteplase.
Interesting. We use Alteplase, but we use it for central lines. So if a central line gets clogged up, you shoot it full of Alteplase, wait like 30 minutes, and it dissolves. So it's used in like different.
Yes.
Yeah, that's interesting.
In strokes, Alteplase is the primary drug of choice, but only under certain conditions. The patient cannot be on blood thinners, and the patient needs to be scanned every which way to make sure they don't have a bleed somewhere. Because if you give Alteplase, they're just going to bleed out and cause hemorrhages somewhere. The shorthand for Alteplase is TPA. So every stroke patients have what's called a TPA window of 1 hour. At my hospital, it's 45 minutes because they want to, be cutting edge and whatever. But there's also kind of sub goals under that, like, hey, within, I'm botching this, but so just as an example, within 15 minutes, let's get a CAT scan of their head. Now that CAT scan's very important. And I'm going to use this as a segue. The CAT scan is very important because the CAT scan is what determines whether they've had an ischemic or hemorrhagic stroke. In a CAT scan, your brain and the blood vessels in your brain, they take a picture of it, and the radiologist can see whether there's a little clot in a vessel or if there's this giant bleed inside your brain. So if there's a giant bleed in your brain, we're not going to give a clot busting medication, right?
So you only give a clot busting medication if it's ischemic. So you would never give it in a hemorrhagic stroke.
Exactly.
Okay.
If someone shows up and has a stroke, you wouldn't just start reaching for the Alteplase.
Right.
Because you don't know if it's ischemic or hemorrhagic until you have that CAT scan of the head.
Is the mechanism that Alteplase works, is it a platelet inactivator? Let me look that up real quick. Sorry, I'm just curious.
Yeah, go for it. It's called clot busting. It might just have some kind of enzyme that breaks down clots instead of preventing clots.
Tissue. Oh, it's a tissue plasminogen activator. Converts plasminogen to the plasmin, which lyses fibrin as well. Oh, okay.
Oh, so it literally busts clots that have already formed.
Interesting.
Yeah.
Very cool.
Which is why you wouldn't give aspirin or something like that, which prevents platelets from forming.
Bingo.
But Alteplase busts clots. Now let's do another scenario. We're going to do another scenario, okay? A patient comes in, right, on a stretcher, ambulance guys wheeling them in, and you walk over so that the EMTs can give you a report on the patient. And they say, this patient fell down because she got extremely dizzy and she's vomiting and she's like really woozy and confused, and she's a little bit weak on one side. So then I look at the patient, and the patient's like having a hard time breathing. They're kind of swaying and they're just vomiting a lot. An experienced nurse would know this looks way more like a hemorrhagic stroke. So a hemorrhagic stroke is when, whether due to chronic hypertension or some kind of lifestyle that damages blood vessels, it could even be an injury to the head, where for whatever reason a blood vessel or an aneurysm, right, or a blood vessel has burst and is now spilling blood directly into your brain tissue.
So an aneurysm is just a weakening of the walls, and it's kind of like an outpouching.
Yeah, yeah.
Where the walls of the blood vessel get really thin, and then eventually they just burst.
Exactly.
Okay.
And that'll cause a hemorrhagic stroke. Hemorrhagic strokes, let me look up real quick. The vast majority of strokes are ischemic. Hemorrhagic strokes will only be like 8 to 18% according to this quick Google search. But that is what it's like. Like every day you'll see 20 ischemic strokes. But like every 2 months, a hemorrhagic stroke will come into the ER. So this patient, everyone's thinking the same thing. This looks like a hemorrhagic stroke. You try to suction the airway to make sure that they're not airway first, right? You suction the airway, make sure they're not choking on their own vomit. You try to get them on oxygen because they're probably not getting enough oxygen from the labored breathing. And you quickly try to get them to CT to confirm it's a hemorrhagic stroke. You've taken their blood sugar and it's probably normal. And then once you know it's a hemorrhagic stroke, then the treatment will not be blood thinners, right? It'll probably be some kind of surgery. And the damage done from hemorrhagic is way worse. And it's usually like very, very lethal too, because there's a very short period from a hemorrhagic stroke to like trying to stop whatever's going on.
Why is it so much worse than ischemic?
So when you're leaking blood directly into the brain tissue, you're increasing the pressure inside of your head. Your intracranial pressure is going up. And that's why the symptoms look a lot different than an ischemic stroke. Some of it's the same. You've damaged half the brain, and so you'll have some one-sided symptoms. But you're also going to get the two-sided symptoms of just increasing the overall pressure in your head. Those symptoms are the things like disorientation and vomiting. You also get intracranial pressure from like concussions and stuff like that. And in babies too, it's really important to monitor the intracranial pressure. Hemorrhagic strokes are way more lethal in that sense because the damage will be much more widespread instead of to just whatever little area
downstream,
the ischemic area. Yeah. So a lot of times when people have hemorrhagic strokes, I think I remember knowing somebody. This wasn't a patient or anything. I remember knowing somebody who had a really bad fall when they were like skating, I think. Ice skating. And so while she was ice skating, she had a hemorrhagic stroke, I think.
Oh, wow.
And so the hemorrhagic stroke caused like permanent, it'll cause permanent things like a decline in cognition or a decline in agility, like it'll make you clumsy. Or in more severe cases, it will forever mean that you have to be on a ventilator and be fed by an NG tube. Like you, especially if it's a hemorrhagic stroke close to the brainstem, then it'll probably turn you into a vegetable like way faster than an ischemic stroke would.
You know, like how my mom works, because she's an occupational therapist, so she works at a rehab hospital, and they do a lot of stroke patients. So like I guess you think about decrease in function, and you don't really realize exactly like what that really means. That means like think about all the things you do in your day that involve like any sort of coordination or movement or using your hands or feet. So since she's occupational, she deals a lot with activities of daily living. So it's a lot of like reteaching people like how to eat, how to put on clothes, how to walk, how to put your shoes back on, how to take a shower, like the normal things you don't think about. So having a stroke and like it affecting a certain part of your body or weakening it, that can be really devastating to a person's independence. And also the fact that once you're weakened, there's more likelihood that you could potentially fall again, you know, and break a hip or some other bone. I mean, most likely a hip, but like you could get injured. So it increases your likelihood of rehospitalization as well in a weird way. Oh, we're looking up what kind of surgery is done for a hemorrhagic stroke.
Yeah.
Oh man,
Stroke. What is
a craniotomy.
Yeah, if the hematoma is large, the neurosurgeon will remove part of the skull to drain the hema. Yeah, that's the only thing that can be done, and most patients don't make it. To this.
Yeah.
But yeah, so patients with a hemorrhagic stroke, it's a serious medical emergency. So they'll open up your brain and drain the hematoma because they need to reduce the pressure inside your head. That is one thing that could be reversible, right? So if you reduce the pressure inside your head, then some of those symptoms might go away. You probably will stop vomiting, and you might regain a little bit of orientation. But what's irreversible is the damage done to the brain by spilling blood on it. So that would be permanent. The brain's not like the liver where it can just grow back.
Right.
Something that it's lost. Let me see. If the brain is swollen, this operation allows the brain to bulge past the limits of the skull and reduce intracranial pressure.
So they'll leave it open.
Wow, that's crazy. But that's past my scope of practice. So the priorities for a nurse taking care of a stroke patient, and the vast majority of these patients will be ischemic strokes. It's very important to continue to do those NIH stroke scales. And the doctor might ask for, your hospital might have a protocol, hey, do them every 15 minutes. Or they'll do it every hour, depending on if it's this is their 5th day in the hospital and you're just monitoring their recovery. And most ischemic strokes I've seen, they regain a lot of their, a lot of it is reversed, but there will always be something permanent going on. I was in the ER, as I often am, and one of my patients came in for generalized weakness. What I remember was that she had a UTI, and so, okay, that's why she's weak, and she's just recovering, being treated with antibiotics. She was just sleepy during my whole shift, and so every time I would come in to check on her, I would always ask, "Hi, how are you feeling?" And she would always respond, "I'm doing well." And I would say, "Are you in any pain?" Because I like assessing for cognition by assessing pain. It's are you in any pain? And she's like, No, I'm not in any pain. It's okay, I'll come back to check on you. I'm just taking down your vital signs. Because she was stable. She was just waiting for a room upstairs. So I would come in and do that every 1 to 2 hours. So I came in once, and I did my usual thing. "Hi." She looked asleep like she had been the rest of my shift. And I said, "Are you in any pain?" And she goes, "Nah." I was like, "What?" So I walk up and I'm like, "Hi, hello? Are you in pain?" "No." And I was like, "On a scale of 1 to 10, how is your pain?" 8.
Oh.
And I was like, "But are you in pain?" "No." So I was really confused. So I get up closer to her and I'm looking at her face. And I'm like, "Ma'am." So I'd start touching her because she's not opening her eyes. "Ma'am, wake up. Hello." And so just instinctively, I take out my pen light and I'm shining it on her to see if she wakes up or whatever. I'm looking into her eyes, and then I kind of straighten her face and I look at her, and I'm like, the first thing that was going through my head is what's going on? Something wrong has happened. She's declined, and it's usually a huge red flag when it's hard to wake a patient up.
Right.
So I say, Ma'am, can you raise your eyebrows?" And so she raised her eyebrows. And I'm like, Ma'am, can you smile for me?" And only half of her mouth smiled.
There it is.
Bingo. I was like, my patient's having a stroke. And this is remarkable because I was so used to patients coming in because they had a stroke. I'm not used to a patient who came in for something else having a stroke during my shift.
Right.
So I get on that walkie and I ask my preceptor to come over because the last thing I want to do is embarrass myself by calling a stroke alert on a patient who's like not having a stroke. But I'm pretty sure she's having a stroke. And so my preceptor comes and I said, like, I'm pretty sure she's having a stroke. And so he's like messing around with her arms and stuff. And finally he checks her face and he sees the one-sided droop and he says, yep, we're going to have to call a stroke alert. So that's what you have to do. You get immediately on that walkie and you let all the nurses and the charge nurse know at the same time, can we call a stroke alert on bed, whatever. And so what that activates is that window. I have to get on that computer and start charting like crazy. So I charted, I immediately did an NIH stroke scale. I got a baseline score. I put in a note about she was last known well at like the last time I gave meds. So now that is the beginning of the TPA window. And then immediately Cody is going over to the CAT scan people and being like, we need this for a patient who's having a stroke. And so it's all hands on deck. We're wheeling her in there and she definitely has a stroke. It's an ischemic stroke. And so the patient got ever so slightly better, but still had obvious facial droop, but was not paralyzed in any of her limbs. So that the only way you catch that is if you're diligent with assessments and seeing your patients. That's the biggest lesson to learn and the biggest thing about strokes. Imagine if I hadn't been rounding on my patients, because she's stable, right? I don't have to go in there unless they use the call light. No. If I hadn't noticed that, I would have, like at 7:15, given report on her. And then when we go in to meet the patient, she is like, has a stroke. And she's like, does she have a history of stroke? And her chart doesn't say so. And so it clearly means you can look at if someone reviewed my charting, they would have seen that I totally just
Dropped the ball,
put in fake assessments, didn't know that she had a stroke. And unfortunately, that happens.
Yeah.
But during school, I remember really admiring this nurse who called a stroke alert. And then when the doctors came in, they were like, why'd you call it? Well, I called it because I came in here and I always come in here and round on my patients. And this time she was having a little bit of a facial droop. And I just wanted to be safe. And I was like, that is a good nurse. And so I was really surprised how soon in my nursing career I faced a moment like that where, hey, the test of a nurse is like the frequency of their assessment, their diligence to round on patients. Because if you don't do that, you're not going to catch stuff like an ischemic stroke early. That's probably what saved this patient. The fact that I caught it early instead of way later. So it'll happen. It's a thing. That is basically in a nutshell the two different kinds of strokes and how nurses work with them. I'm David.
Matthew.
And this is
the Handoff Report.
Bye.